Good morning, everyone. Happy Thursday. Welcome to the latest edition of the morning meeting. I will kick it off as usual with a couple of quick legislative updates before we kick it over to our fantastic guest. Um, this morning, we are anticipating committee notices to start coming out for next week in the Ohio General Assembly. We saw a flurry of activity in the House Health or Children and Human Services Committee Tuesday morning. So we did see Director Wente come and talk about program integrity in our publicly funded childcare system in a direct response to House Bills 647 and 649, which are both being heard in that committee. We saw just two pieces of proponent testimony for House Bill 647. That's the bill being sponsored by Representatives Plummer and Young that is being created in partnership with the Department of Children and Youth. We did not see any additional testimony on House Bill 649. That's the bill by Representative Williams. He indicated during his sponsor testimony that some of the video surveillance components of that bill are likely to be removed, and he is working with stakeholders on a substitute bill, which means that the entire bill is going to be revamped and reintroduced in the coming weeks. So if you're not already signed up for our newsletters, we will have a legislative update with a little bit more detail coming out tomorrow morning. We'll continue to update our blog on all of these pieces of legislation, and we'll also let you know if there are opportunities to testify and come down next week. So we might get that notice yet today, but definitely by end of day tomorrow. There was also legislation on a bill regarding certification of midwives. We are currently still researching more on that bill and we'll share more information. We're touching base with some of our folks that work most deeply in that space, and we want to make sure we do all of our research before we offer any more information out on that one. But that is House Bill 537, sponsored by Representatives Miller and McLean. And that was just sponsor testimony. So a substitute version of that bill came out as well that defined freestanding birth clinics and provided some more guardrails around who needs to be on site at a freestanding birth clinic for a birth experience. So we will share out more on that bill as it continues to move. And finally, one more that we're tracking was in the House Insurance Committee related to paid family leave insurance, and that was just a sponsor hearing as well. So lots of things happening as the legislature is convening into March. They'll take a break over around Easter and then wrap up for the primary May 5th. We anticipate some more activity in June and then a summer break. So we'll continue to update in our newsletter and happy to talk more with folks one-on-one. I know we've got folks on this call with a lot of different interests in different pieces of legislation, so I don't want to get too weedy on any, and I want to give the bulk of our time to our wonderful guest, Christine Sander. I'm going to share a little bit about her background and then pass it over to her to pop up her slides. Christine is the Senior Director of Community Wellness at Nationwide Children's Hospital, one of our longtime friends. We were grateful to them for hosting our roadshow in 2024. And Christine has been leading the hospital's Pediatric Vital Signs Initiative and is the director of the Ohio Better Birth Outcomes Collaborative, which is another way that we've gotten to meet her. So her success in building partnerships and driving population health strategies has really helped reduce infant mortality in Central Ohio. And her work now includes broadly improving child outcomes in other regions. I could go on with more of Christine's background and bio, but I really want to just give the time back to her because the work she's doing is incredible. And we're really grateful to have you here today. Good morning.
Good morning. Thank you so much for the kind words and the intro and for the invitation. I'm really excited to be able to share with you a little bit about OBO, as we affectionately call it, because Ohio Better Birth Outcomes Collaborative is a little bit of a mouthful. So I'm going to try to just make sure I can click the there we go, full screen. So thanks. I appreciate it. I'm excited to share with you. I am just going to start with a little bit of an overview of OBO's structure. I want to go into some of the community level impacts we've been able to achieve with this type of collaboration, and then also share a little bit about how we're thinking of replicating this type of model in southeastern Ohio. So OBO is really at its core a quality improvement collaborative. It is led by the four health systems that you see to the right, and it really sits within this much larger ecosystem to the left that you see here. So obviously, with any kind of health, population health activity, there's the federal and state landscape that exists. Locally, we have Celebrate One as our collective impact organization driving this work. And OBO is really how we come together around the healthcare and what I'll call healthcare plus interventions that feed into that collective work. So OBO's been around in its current form since 2014, but actually existed prior to that in a much more casual way with just a group of physicians, whether OB, maternal fetal medicine, neonatology, kind of convening on a regular basis to talk about this issue of infant mortality and early prematurity and how to make it better. So what started as just kind of this casual over coffee, probably similar to a morning meeting on a regular basis, has really evolved into what has been a pretty formal structure over the past 10 years that has resulted in some long-lasting impacts in the community that help us do this work. Um, so the structure of OBO, just a little bit about how it works and who's a part of it and how it's facilitated is here on the screen. So we have some pretty intentional alignment of multiple layers within each of these health systems that are a part of OBO, as well as the three federally qualified health centers that provide prenatal care in our community. Our board consists of the chief medical officers of those organizations. It also includes the Central Ohio Hospital Council president. Central Ohio Hospital Council also serves as the fiduciary agent of OBO. So we are very aligned, and a lot of the interventions that we do are collaborative, and we're kind of all working together at that CEO, CMO, and then down through the hospital systems level. We also have the Columbus Health Commissioner as part of our board. That board meets quarterly. They review the outcome data, so looking at infant mortality overall, the racial disparity, some key indicator measures, and then how we're performing on these priorities to the right. So OBO really focuses on that alignment on two priorities. One is directing some of the pooled funding that the hospital systems contribute into investing into evidence-based strategies within the community, primarily through community-based agencies. And then the second way is through the implementation of those shared priority quality improvement projects that happen in the clinical spaces where families are seeking care. So the board looks at the outcome data and then tracks our progress on those two priorities and just really overall guides this work, asks great questions. I'm always energized every time I leave there to think about how, reflect upon how invested the chief clinical officers of all of these healthcare institutions are in this outcome of maternal and child health. The next layer of alignment that we have is a little bit closer to the work in our operations team. So that group is comprised of the women's health leadership and community affairs, government affairs leadership at each of those systems. And so this is the group that is often removing barriers, helping weigh in on where the funding is invested, helping accelerate progress on those shared projects if there's nuances within each health system of how that work can move forward. This group meets on a little bit more of a frequent basis. I would say every other month-ish as a group, and then in between there are certainly individual conversations with each system. The third layer is where I like to say the magic happens. That's in the frontline clinical teams, the work teams that actually are responsible for making the changes in the direct care settings. So these are the physicians, the nurses, the social workers, the PCAs, the MAs, the registration staff, the security, whomever is in and around those prenatal care clinic areas, the triage areas, the postpartum areas, where we've identified these shared priority projects. These are the folks that are making the changes. And so we meet with these groups on a very regular basis, whether again in a group toward a common priority or individually as health systems as they navigate those changes. All of this work is facilitated by our OBO team, and that team is employed at Nationwide Children's Hospital, as you mentioned, as part of our population health strategy. So, population health, assuming the care, and really what that means in this case is assuming responsibility for health outcomes, not just health care outcomes, is one of the pillars of our strategic plan. In fact, it's one of the four areas that our board and our senior leadership have said makes us different than any other children's hospital in the country. So the level of investment that we have with this as an example is something that we have done historically over the past decade plus, and that we'll continue to do. So, a little bit about the level of alignment or the community level impacts that this level of alignment has really contributed to the work. I want to talk through each of these, and then I have a couple slides to go into a bit more detail to show you kind of what I mean. So, the first is access to data. And I'm sure I saw some of the names before I started screen sharing, so I know enough to know that all of you know with any child health issue, there is not just one cause, there is not just one solution. So data is really important. And so it's important, obviously, not to just to track the outcome, the actual overall rate and the disparities, but to really help us identify where are the gaps in the work that we're doing. What are the things that the data is telling us that show us we have an opportunity to intervene on that we're not currently doing today. So this structure has enabled us to have a data use agreement with the state to access vital statistics to do that. And we are able to access that and look at the aggregate information, but we also have the ability to share identifiable information in a very secure legal way with the hospital systems who are providing care, delivery care primarily to this population, and enable a level of chart review within those systems that would not otherwise be possible. And I'll talk a little bit about how that works in a minute. The second area is funding. So, this structure that exists in its current form over the past 10 years has resulted in sustained investment from the hospital systems themselves. So, they directly contribute to the OBO activities, not the staffing per se, but the actual investment that the hospital systems make into those community based agencies. And that is important to note that it's over, and one of the important things I want to note is that that is over and above what each of these systems do as it relates to community benefit in maternal and child health. So each of the health systems have their own programs that are operating at a loss or below that break even space. They are all investing in kind of over and above services to help this outcome. But this funding is specific and outside of that and really geared toward bridging that gap between what is happening and being identified as needs in the clinical space and the community agencies that are better suited to provide some of those services to help mitigate those issues, probably better suited than the hospital systems themselves, and funneling that funding to them. Um, so the other component of this, so in addition to that sustained hospital funding, it's also opened up some doors to secure external funding into the community for the same priority. The best example I have of this is the HRSA Catalyst Award, of which Dominique is very familiar. So this was a grant that is under the Healthy Start umbrella of HRSA that is specifically designed to go to communities that are dealing with a persistent racial disparity. So we were one of 6 communities nationwide that received this award. It was a new grant structure under HRSA. We're in year 4 currently, and we would not have been eligible for it had we not been able to demonstrate the longstanding history we have of implementing change at a system level in the prenatal care clinics. So if we had not had kind of the OBO track record, the track record of plugging in and working collaboratively with Celebrate One, we would not have been eligible to even apply for that funding. Again, we're in year 4 of that. We've been able to, with that funding, introduce community health workers into a space that they had not been before, into the prenatal care space. So we're excited about continuing that and sustaining that going forward. The third bucket is partnerships. And really the point there is the ability to get to the level of robust far-reaching partnerships and what that does when you have 8+ organizations providing prenatal care, reaching that population and the ability to impact change. The best example I have here is the medical legal partnership that we've established in partnership with Legal Aid of Southeast and Central Ohio. So a medical legal partnership in and of itself is not unique. Nationwide Children's has one that is a combination of in-house support and a partnership with Legal Aid. But what's unique about this is that it is available across 8 different organizations and then some, and targeted to a specific population. So in our community in Central Ohio, you can be pregnant and going to a Moms to Be session at OSU. You could be going to seek care at Heart of Ohio at one of their prenatal care clinics. Wherever you might be, if you have a legal need and is identified through some of the evidence-based screening questions, you have access to this dedicated door with a dedicated intake specialist and program that can connect you in a more expedited way to legal supports. That is something that through the past couple of years, as we've been working on this in partnership with Legal Aid, we've not been able to identify its existence in that kind of form anywhere else in the country. So a bit more about the data. Excuse me. I wanted to give you just an illustration of a couple of the things that really how we look at the data from an outcome perspective. So this is a chart that we have that is a good illustration of how we look at much of the indicator data. This in particular is our infant mortality rate. The blue line, to orient you, is looking at a rolling 12-month average for statistical stability, but also kind of ease of digesting. So each one of those dots represents 12 months of data. And then the red line overlaid on top of that is actually where the rate ended for the year. So you can see by the end of each year, the blue dot line and the red line are kind of intersecting to show that 12 months of data is lined up where that annual year is. So you can see the rolling 12-month, the annual line, and then the green line is the healthy people goal. So first 2020 and then 2030. And then we have the ability to look at this by race. And so this really is pretty poignant at illustrating where our big goal currently is. As you can see, we've exceeded the goal already for non-Hispanic white population and are not looking to lose progress there, but certainly have some ways to go in reducing the disparity. So we look at this for not just this measure, but early prematurity, teen pregnancy, entry to prenatal care, deliveries with no prenatal care. So we have a scorecard that kind of pulls all of that together, and then we use these charts to look at long-term trends and indicators. On the qualitative side, the collaboration has also allowed us to plug into the 2 child fatality review boards that exist in the county and help us conduct those hospital chart reviews. So I mentioned we are able to share that identifiable data from the vital statistics side. And we are able to based on where the patient was delivered. And what we're able to do with that is each hospital system conducts a chart review that looks at the same discrete elements that are available in the EMR, populate that into a REDCap database, and then share that back with our OBO staff, and we can then aggregate over across the systems in a de-identified way from a theme perspective. And so, unfortunately, because of the structures of the review boards, the HIPAA, the legal, ORC, all of the things, we are unfortunately not able to do a side by side by side, apples to apples analysis of the same data on the same individuals. But what we are able to do by having presence in these 3 buckets is pull themes that are showing up across each and explore those themes to the extent that we can with available data, either in the vital statistics or in the hospital EMR. Again, toward us helping to identify gaps and action items. All of that data, all of that vital statistics data, the chart review data, that qualitative data leads us to inform our priority projects. So this slide represents our current blue chip projects. So it's certainly not everything that we're doing, but it's those things that we're reporting to the board on a regular basis and that we're really tracking toward making an impact in the community. These have evolved over time. So I mentioned this, the structure that OBO exists in today has been around for a decade plus. So when we first started this work, we were working on highly clinical areas, things like progesterone prescribing, contraception access, regionalized deliveries of high-risk patients in cooperation with Central Ohio Hospital Council. And so that's really evolved over time and space. Those interventions were implemented, they were sustained, they had their impact, and now we're moving toward more of that social determinant integration with what else are we able to mitigate for families and support families with as they're coming through our clinical spaces. The implementation approach that we use for these projects is quality improvement, as I mentioned. So we don't, because these are different systems, we don't try to overly prescribe how they get the work done. What we try to do is establish common elements and then a common tracking system. So each system, as they're implementing, will adhere to kind of a common set of elements that is needed for implementation, and then the same tracking mechanism of kind of numerator and denominator and how we're going to count how many patients were affected by or were impacted by the change. And then again, we aggregate that data across sites and we come up with a community-wide measure to say 60% of the patients who were seen in our prenatal care clinics were referred to home visiting over the last quarter. A bit more about the funding. Again, this has evolved over time. We started this funding pool with a 3-year commitment, and then the hospital systems agreed to an additional 5-year, and then most recently in July of last year agreed to a subsequent 5-year as the work, obviously, especially as relates to the disparity, is not done. So you can see again our current priority funding streams. And this is operated really like a grant opportunity. So again, we're pushing money to community agencies who are better suited to performing this work. You can see in the future category 2 opportunities that we have identified in that data process that I just described. So pregnant women who are using substances and or kind of utterly disconnected from any system in any kind of way is been one of the focus areas that's come up recently in that data. And finally, just a little bit about our regional expansion. So, um, excuse me. This looks different regionally for a couple of different reasons, 2 of which are just from a rural hospital perspective, it's different, right? The service area reach is different. The proximity to each other is a little bit different than having 4 systems that are in each other's backyards in one county. So we knew we'd have to think about it differently, and we knew we'd likely have to get some external funding to jumpstart what we are trying to do in this type of collaboration. So in 2024, we were successful with that through HRSA again, and this time with a traditional Healthy Start grant. This was the first rural Healthy Start grant in Ohio. Which we're excited about, and even more excited that it was reauthorized in the budget or approved and included in the budget. And what we've been trying to do over the past 18 months or so is really overlay the elements that have contributed to OBO's work and success over the past 10 years here into the Healthy Start model. And so some of the things we've been able to accomplish with that are establishing this community consortium with healthcare and non-healthcare around the table on a regular basis, agreeing on projects, agreeing on gaps, conducting focus groups, and informing the work. We've been able to embed community health workers into the prenatal and pediatric clinics at 2 health systems, Adena Medical Center and Southern Ohio Medical Center. We've established a medical legal partnership through an expansion of our relationship with legal aid. We are identifying some education opportunities and partnering with the Ross County Public Health Department and several other local agencies to implement some education strategies. And we are up to around around 500 families that we've served through those community health workers over the past 18 months. So we're really excited about how this is going. We're looking forward to seeing some impacts in the outcomes here in the next year. And we'll keep tracking toward improvement again in those big outcomes with this work. Thanks again for your time. Oh, good. We still have 5 minutes. So I'm happy to answer any questions. This is our team. We have added a couple folks recently. So these are our core members. But we are able to be reached through the website or any of our emails are just first name dot last name at nationwidechildren's.org.
Thank you so much, Christine. This is incredible. And your team is also wonderful. We've had the opportunity to run into them at different advocacy opportunities, and they're a fantastic team. We do already have some questions. One, Caitlin, you read my mind. With the expansion into Southeast Ohio, Caitlin on our team is asking whether there might be any overlap or collaboration with some of the rural health transformation dollars flowing in from the federal government here this year.
Yeah, that's a great question. So, two of the things that we know about, I think, that are coming out of that more with more information at least, are the workforce opportunities. So, we've partnered with an agency or a university who's seeking that. I think that one's a statewide grant, but
Mhm.
with focus on the southeastern area in terms of supporting. Everything from high school mentoring all the way up through some shadowing opportunities with community health workers specifically. That was called out in the RFP or in Ohio's response in general a couple of different times. So we are definitely on board and thinking about how that intersects. The other piece that was called out specifically that I think we're waiting a little bit on more information for is home visiting and the ability to expand. We already have, through a relationship between Nationwide Children's and Ohio Health and several others, some small expansions of home visiting into Athens and some of those southeastern pockets. But I think there's an opportunity to think about how to do that more broadly and kind of expand that capacity for perinatal supports in general, certainly home visiting, but also doula and community health worker and other supports, particularly in those maternity desert areas, or maybe not a desert, but certainly not a place with 8 organizations who provide prenatal care.
Absolutely. Oh, we love to hear that. And if we can be helpful at all in advocating for that type of flow of resources, we are all in.
So appreciate that.
Yeah. Do other folks have questions? We've got a couple minutes left. I want to make sure other folks get to ask questions as well. Feel free to pop off mute. And that lines up a lot with what we heard on our roadshow when we were in Southeast Ohio too, Christine. The
Oh, good.
workforce
That's good to hear.
component and the home visiting.
Yep. Excuse me.
Getting some love for the Queens Villages. Yep,
Yes.
from around the state. Okay. Let's see. Christine says, or I'm sorry, Candace says, I love learning about this great work, specifically the alignment with hospitals, funding support, and your definition of population health, solely focused on value-based payment arrangements with payers. Would love to learn more from
Yes, we'd
Candace
be happy to
Severs.
share more. That is really our pediatric vital signs program, which is really 8 measures. Infant mortality is one, but there are 8 other measures of child health, which we monitor and actively work to improve, regardless of whether we've seen the kids, whether they're part of our accountable care organization. It's really looking at that county or multiple county-wide indicator.
And maybe, Candace, if there's more to chat about there, we could. Oh, Candace, did you want to come off mute? I see your hand as well. I was going to say we could e-intro you guys after the call if you're not already talking.
Yeah, thank you, Brittany. Christine, I would love to meet with you to learn more. I just want to clarify that what I really appreciate about your definition of population health is that it's not a value-based payment definition, which we traditionally see within the healthcare system. So I just really want to commend you for having a really innovative approach to population health that I would love to talk more about how we truly replicate that here in Southwest Ohio.
Yeah, I would love to chat more about that. That would be great.
Awesome. We'll do an e-intro to make sure you have each other's contact info after this. And I know we're at 10, but we've got one more really good question.
Yeah,
If you have another minute, Christine, we
I
have a
do.
question around the Partners for Change grant.
Oh,
If you
yes.
could share any connections between that and the work that Obo is doing,
Yes,
that would be
absolutely.
fantastic.
Thank you. I meant to mention that earlier and I completely forgot. So thank you for asking that question. So yes, we are one of the, I think it's again another kind of example of our collaborative impact in that partnerships category. So we are working actively on the Partners for Change grant. We have, just started the focus group part of that. So a lot of what I talked about with that gap analysis work is really being driven by that Partners for Change structure. And so, for those of you who may not know, that is a Department of Children and Youth initiative partnering with Cradle Cincinnati to pull together several of the communities in Ohio to do this. What I keep calling a formal gap analysis, I think what Meredith at Cradle Cincinnati calls it is an all teach, all learn model. Um, Again, primarily with Cradle Cincinnati, spreading the structure and the work that they've done, and the other communities kind of assessing, where are the pockets and pieces that might be missing. And what I've loved about it is that it has evolved to there are things that Toledo is doing that we are not in Franklin County. There's things that Cleveland's doing that even Cincinnati is not. And so it's been this great opportunity to really for Ohio to kind of share information in an intentional way and rise all boats. And so we have been convening the key stakeholder group for that Partners for Change work. We are in the recruitment process right now for focus groups that are really going to help us confirm the themes that we're seeing in the data or validate some of the themes that we're seeing, but then shift us more toward what can we do about it and really use that community voice to help drive interventions that can fill those gaps in a meaningful way. Um, so yes, definitely connected there. I think the other, I'm also connected to the Toledo work, as mentioned. Children's Hospital Toledo is one of the members of the stakeholder team there that is being led by Healthcare Collaborative of Northwest Ohio. We work very closely with Dayton Children's, who's leading that work in Montgomery County, and we are also kind of infusing the learnings and key themes from that work into the Southeastern. Model as well. We were fortunate to have some funding to do specific focus groups in Southeast Ohio. So the community voice there will obviously be different than what is here in Franklin County. So that's one thing that we are going to try to use some of that Healthy Start dollars to help support in making sure that community voice is infused there in the same way.
Thank you so much for that, Christine, and love to kind of see the energy around that grant and effort, how it's manifesting statewide, but in a community responsive way because each community's needs and challenges are so different.
Yes, that's a great explanation, a great summary.
Well, we appreciate you so much sharing all of this great data this morning. We will send out the slides afterward. We look forward to continuing to advocate with OBO and work with you all at the State House and beyond, and just greatly appreciate the work that you do. So thank you so much for being here, and we
Thank
hope you have a
you.
great day.
Thank you. You all as well. Again, appreciate the time. Have a good one.
Thank you. And thanks, Dominique, for introducing us to Christine. Take care, everybody.
Bye.